Thank you very much, everybody. Good evening. So as was introduced, I will be discussing on primary aldosteronism. And, my goal is to provide some updates on how our thought process on primary aldosteronism has evolved over many years, and to provide a practical approach to the clinical diagnosis and management. There are many clinical topics. We may not cover them all, but we'll see how time allows. I will start by first reviewing what is primary aldosteronism, because I think understanding the pathophysiology is the most crucial aspect of managing clinical disease. Dr. Jindal already gave a beautiful review, so I won't spend too much time here, just to show the key concepts that were already reviewed one more time, which is that primary aldosteronism is a renin-independent aldosterone production that occurs despite a volume expanded state, and often even though you're hypokalemic. So volume expansion, hypokalemia should suppress aldosterone, but the idea here is there's autonomous aldosterone production, even though it should be suppressed. So one or more adrenal foci in the one or both adrenal glands are overproducing aldosterone. The circulating volume is expanded, and renin and angiotensin II are appropriately suppressed. This is a glomerulus and a cartoon of a nephron. As we know, in normal physiology, the majority of sodium and water reabsorption occur in the proximal nephron under the auspices of angiotensin II. So in primary aldosteronism, because angiotensin II is suppressed, this process is diminished, and more sodium will be delivered to the distal part of the nephron. In the distal part of the nephron, in the principal cell, aldosterone interacts with the mineralocorticoid receptor to induce ENaC-mediated sodium reabsorption, and in parallel, water. So what has happened here is there's a shift. Sodium and water reabsorption used to happen dominantly in the proximal part of the nephron, and now more of it is happening in the distal aspect of the nephron because there's more distal sodium delivery and excess aldosterone. And in addition to this volume expansion, for every sodium cation that's reabsorbed, one potassium or proton must be excreted. So this is a vicious cycle. You have more distal sodium delivery, which results in more sodium reabsorption, more volume expansion. This increases blood pressure. This increases glomerular hyperfiltration, which further increases distal sodium delivery, and so on and so forth, all in conjunction with potassium and hydrogen ion excretion. So what is primary aldosteronism? It is an inappropriate, relatively non-suppressible renin-independent aldosterone production. This results in excessive activation of the mineralocorticoid receptor in the kidney, a vicious cycle of volume expansion that increases blood pressure, potassium and hydrogen ion excretion. And this increases the risk for cardiovascular disease regardless of blood pressure, because the mineralocorticoid receptor is expressed in the heart, in the vascular endothelium and smooth muscle, where it can cause necrosis and fibrosis. The clinical syndrome reflects the severity and duration of this aldosteronism. So I think one important point here is blood pressure and potassium are dependent features. A patient with primary aldosteronism does not need to have severe hypertension or hypokalemia. In fact, the blood pressure and potassium will change day to day depending on how much distal sodium delivery there is. So if you eat a high sodium diet, this will be worse. If you restrict sodium, you can improve these features. But the hallmark biochemical features are suppression of renin, and when renin is suppressed, an inappropriate and dysregulated production of aldosterone. And this inappropriate aldosterone production, this is the entire interpretation that varies from person to person and place to place that we will focus on today. So a key point that was mentioned earlier is that there is a paradox. All hyperaldosteronism is not the same. When we are sodium loaded and volume expanded, such as in primary aldosteronism, such as in heart failure, this hyperaldosteronism causes mineralocorticoid receptor activation that induces cardiovascular injury. In contrast, when we have hyperaldosteronism in the context of sodium restriction and volume contraction, it's physiologic. It preserves volume and causes potassium excretion. And why this dichotomy occurs on a molecular basis is not completely understood, but this is the basis for why primary aldosteronism needs to be diagnosed and treated early. So this point was made earlier. We are designed to exist in a sodium poor and potassium rich environment where high angiotensin II and aldosterone production maintain homeostasis. Unfortunately, our environment for most humans has changed. We now live in a sodium-rich, potassium-poor environment where almost any aldosterone production is likely to be toxic to cardiovascular tissues in this scenario. So the first clinical concept I will review is the variability of aldosterone production. I think as endocrinologists, we all know that hormones are not produced in a constant stream. They vary by diurnal variation, pulsatility, etc. The same is true for aldosterone, although I think this feature is poorly recognized or underestimated. We've known this for years. So these are normal volunteers put on a high sodium diet. On a high sodium diet, renin and angiotensin 2 and aldosterone should be completely suppressed. And what you see is that even on a high sodium diet in a 24-hour period, the aldosterone production is variable. It pulses every hour. There are burst-like secretions of aldosterone. And the same is true for a patient with primary aldosteronism. You can see even though the aldosterone values are much higher, there is a diurnal variation throughout the day, which is not surprising. But on top of the diurnal variation, there are pulsatile releases of aldosterone throughout the day. And what we've seen over and over is compared to the average aldosterone value throughout the day, the values can range from 50 to 400%. So a huge range of production. Here's one example. These are 50 patients with confirmed primary aldosteronism, meaning every single one of them has undergone a confirmatory test, dynamic test to prove they have primary aldosteronism. It's undisputed. And in black, for each person, you see multiple aldosterone measurements on different days. And in red, you see their average of all of those measurements. So what you can see, for example, this patient has a mean aldosterone value of 30 nanograms per deciliter, but on one day, the aldosterone can be as high as 50, and on another day, it can be as low as 15. Here's a patient with a mean aldosterone value of 15 nanograms per deciliter, but on one day, it's as high as 35, and another day, it's as low as 7 nanograms per deciliter. And you can see the range can go from 5 all the way to 50 nanograms per deciliter. In this series, 3/4 of the patients with confirmed primary aldosteronism had at least one aldosterone less than 20. More than half had at least one aldosterone value less than 15, and almost 1/3 had one aldosterone value less than 10. Okay, and that's because the coefficient of variance of aldosterone is about 30%, and for the aldosterone to renin ratio is even higher, almost 50%. What this means is on any given day, you might see a value that seems high, and you might see a value that seems low. So the absolute value of aldosterone is not as important as the suppression of renin, as was mentioned earlier by Dr. This is further compounded because many aldosterone assays are switching from the immunoassay methodology to liquid chromatography tandem mass spec, LC mass spec assays. And LC mass spec assays for steroids are much better, accurate, reliable, but we need to recalibrate our expectations. The values that are reported are about 25 to 30% lower than immunoassays. In other words, if you measure an aldosterone on an immunoassay and the result is 10 nanograms per deciliter, on a modern LC mass spec assay, the result may be reported as 7 to 7.5 nanograms per deciliter. And this is actually true for most steroids, cortisol, testosterone, etc. So what does this mean? Aldosterone production in primary aldosteronism is pulsatile, variable, and it manifests across a wide range. A single circulating aldosterone level is not a reliable indicator of integrated physiology. And more importantly, a single low value should not exclude the diagnosis. A single high value may be very important, but a single low value doesn't necessarily exclude the diagnosis. If you use LC mass spec assays that are going to be used more and more common, you have to realize that lower values are going to be reported than the traditional immunoassays. And for this reason, we need to recalibrate our diagnostic screening thresholds. And I'll show you how that can be done shortly. Okay, another concept that builds on this variability is how common is primary aldosteronism? So there's many ways to address this question. I would say almost every method to understand how common it is somewhat flawed, but the answer is it is very common. So a very common approach in studies has been to take patients, in this case, hypertensive patients, and systematically screen them. Everyone gets a renin and an aldosterone. And in this study, they said anybody with an aldosterone renin ratio greater than 30 and an aldosterone level greater than 10 nanograms per deciliter is a positive screen. Okay, this is the rule they applied, positive, negative, no middle gray area. If you had a positive screen, then you underwent a suppression test, either saline suppression, captopril suppression. And they created, again, a line, positive, negative. It doesn't matter what value they used. What's important is they used a very specific line. And when they did this, 6% of the total hypertensive population had primary aldosteronism, which is a lot of people since, as was reported earlier, over 1 billion people in the world have hypertension. But what's more important than the total prevalence is the distribution of prevalence. So what you can see is if you had severe blood pressure, 160 over 100 or higher, the prevalence of primary aldosteronism was 10 to 12%, very high. I will call this overt or classical primary aldosteronism because these patients should have been screened for primary aldosteronism. And if you did this, you would have found a very high percentage, 10 to 12%. But you can see even in milder hypertension, blood pressure 140 to 160, 4% are found to have overt primary aldosteronism. And I call this unrecognized, but still overt. You never would look for primary aldosteronism here typically. And what's important here is you can change the screening and confirmatory thresholds. You can make the levels lower and you will find the prevalence goes up. You can make the thresholds higher and you'll find that the prevalence goes down. You can manipulate the prevalence based on what you think a positive screen or confirmatory test are. So I'll show you how to think about prevalence in another way. This is a study we recently did that tries to employ no threshold diagnostic that looks at pathophysiology across a continuum. So this is a study in the United States, and I think data in India, in other parts of the world may differ, but I suspect it will be very similar. And what we did was we conducted oral sodium suppression tests on everybody. So this is one of the many dynamic physiologic tests that can be done to prove someone has abnormal aldosterone production. You eat a high sodium diet for many days. On a high sodium diet, your volume expanded. On a volume expansion, renin and angiotensin 2 are maximally suppressed, and aldosterone should also be maximally suppressed. And if it's not, the degree of aldosterone suppression tells you the degree of dysregulated aldosterone production. And we did this across the entire blood pressure spectrum, in normotensive people, in mild and severe hypertensives, even in resistant hypertension. And these are the main results. What you're looking at is the 24-hour urinary aldosterone excretion rate when patients are on a high sodium balance with renin and angiotensin 2 suppression. And you will see this in every form of blood pressure. And what you expect is aldosterone should be maximally suppressed. But this is what you see. These are the results of aldosterone production over a 24-hour period ordered from lowest to highest, first in normotensive people. And you can see that many of them suppress aldosterone appropriately, but some suppress less, and some cannot shut down aldosterone production at all. Okay, so I will describe this as a severity spectrum of non-suppressible renin-independent aldosterone production, which is the definition of primary aldosteronism. In other words, these are varying degrees of primary aldosteronism from severe and overt to very mild. And you will see the same pattern in stage 1 and stage 2 hypertension, and also in resistant hypertension. The difference is the magnitude or the amplitude of this severity goes up in parallel with the severity of blood pressure. And so why I'm showing you this raw data is to demonstrate that primary aldosteronism exists across a full distribution, a continuum. It is not a yes-no binary diagnosis as we typically define it. In fact, so far in this talk, I have not defined primary aldosteronism based on any diagnostic threshold. We've only defined it based on a concept. But if you look at this concept and then you draw a line, so the official diagnosis on this dynamic confirmatory test is any aldosterone above 12 micrograms for 24 hours is primary aldosteronism. You can see that this definition is entirely arbitrary. It bisects a continuous distribution. And if you look at this, people above this line have primary aldosteronism, but what about the people below this line? They also have primary aldosteronism. It is only milder. And so if you use these definitions, you can come up with prevalence estimates, but you can change these prevalence estimates very easily by changing the definition. If you used 12 micrograms, you would find that 9% of normotensives, 15 to 20% of hypertensives, and up to a quarter of all resistant hypertensives have primary aldosteronism. You can increase this prevalence by saying, if the renin is suppressed, how high is the prevalence? So if your patient has a low renin, a very low renin, the prevalence is even higher. 11% in normotensive, 20 to 25% in hypertension, and almost half of resistant hypertensives. Okay, so if a resistant hypertensive patient has a suppressed renin, 50% chance that they have overt primary aldosteronism. Now, if you had used an aldosterone to renin ratio to detect who might have this disease, only 25 to 50% of these individuals would have been detected. So for example, in resistant hypertension, where your pretest probability for primary aldosteronism is very high, an aldosterone to renin ratio of 30 has a sensitivity of only 26% and a negative predictive value of only 80%. In other words, it is neither good for detecting or excluding the possibility. And why is that? The real answer is aldosterone levels vary. So in resistant hypertensives with confirmed primary aldosteronism, on the day of testing, 25%, a quarter, had an aldosterone value less than 10 nanograms per deciliter. So you can see that just because you have confirmed primary aldosteronism doesn't mean that the circulating aldosterone level at every moment of the day will be high. It can vary quite a bit. So as I said earlier, and a low aldosterone value, for example, less than 10 nanograms per deciliter is not really low. It's just on the lower end of the assays that we use. And it doesn't exclude the diagnosis because aldosterone production is pulsatile, it's variable. A single value doesn't reflect continuous or 24-hour integrated physiology and should not be used as a reliable exclusionary criteria. So here's another example of how common primary aldosteronism is. This was the Pathway 2 study. This was a randomized controlled trial that used to investigate what is the best fourth drug for resistant hypertension. In other words, if a hypertensive patient is on an ACE or an ARB, calcium channel blocker and diuretic, and you still need something for blood pressure control, what should be used? And what they did was they took patients with resistant hypertension, and a hypertension expert excluded secondary hypertension. In other words, they measured a renin and aldosterone, and they themselves decided, I don't think you have primary aldosteronism because the aldo-renin ratio or aldosterone is not high enough. And then they entered this study where they were randomized and crossover to spironolactone, doxazosin, bisoprolol, or placebo. So alpha blocker, beta blocker, or MR antagonist, or placebo. And in short, this is a famous study published in the Lancet because it showed that spironolactone was the best drug. Mineralocorticoid receptor antagonist lowered blood pressure more than alpha blocker, beta blocker, or placebo. And it did so by a huge margin. But when did it work? It actually worked best. Here you can see the blood pressure reduction with spironolactone as a function of renin, aldosterone, and aldosterone to renin ratio. And what you see is striking blood pressure reductions, a 15, 20 millimeters of mercury reduction in resistant hypertension when renin is very low and suppressed, when aldosterone is higher, and when aldosterone to renin ratio is highest. But if you recall, these patients were determined not to have primary aldosteronism, yet you see this pattern. So these were excluded because the aldosterone and aldosterone renin ratio were not deemed to be high enough for primary aldosteronism, but what you're seeing is primary aldosteronism. A substantial proportion of patients who are determined to have idiopathic resistant hypertension actually have biochemical renin independent aldosterone production that also responds really strikingly to a mineralocorticoid receptor antagonist, and also amiloride, an ENaC inhibitor. But these were all misdiagnoses because we had set our threshold for aldosterone to be higher than this. Okay, so this was how variability resulted in exclusion or false exclusion of the diagnosis. So the prevalence of overt primary aldosteronism is high. It's mostly unrecognized. But beyond overt primary aldosteronism, there is a continuum of renin-independent aldosterone production that I showed you, a severity spectrum of primary aldosteronism that ranges from mild to severe. And this entire spectrum is below the current or accepted diagnostic radars and thresholds, and therefore is completely unrecognized. And the reason this is important is because this continuum of renin-independent aldosteronism is associated with cardiovascular risk. Normotensives who have this phenotype develop hypertension at a much higher pace. Hypertensives who have this phenotype develop cardiovascular disease and elevations in their blood pressure at a much higher pace. So this is a pathophysiologic continuum of primary aldosteronism that we know how to treat, but we're not diagnosing. Okay, so this is what Dr. Funder, who is the chair of the hypertension and primary aldosteronism guidelines, has described this as a need to recognize the true prevalence of primary aldosteronism to include dysregulated or inappropriate aldosterone production, to discard the strict definition of primary aldosteronism, and to change the guidelines, to radically reconstruct recommendations. And I think they are working on changing the primary aldosteronism guidelines for the Endocrine Society right now. So with this background, we can now talk about the diagnostic approach. How do you take all of these features, variability, high prevalence, and do a better job at diagnosing and treating patients? So I think when it comes to diagnosis, there are two philosophical approaches, and I really emphasize philosophical approaches because each clinician, each endocrinologist, cardiologist, nephrologist may pursue this slightly different based on what country you're in, whether you're in India, USA, Europe, what your practice is, who your patients are, what type of capabilities, availabilities of testing, finances, etc. So I'm going to present both, and you can use whichever philosophical approach or intermediate that you think is best for you. Philosophy one is the purist approach. Okay, and the purist approach is to eliminate all potential confounders of renin and aldosterone. And this is the approach that is generally recommended by most guidelines, although I think this is going to change, and is practiced in many parts of the world. So the purist will remove all confounding medications. They will stop mineralocorticoid receptor antagonists and ENaC inhibitors, but also ACE inhibitors, ARBs, beta blockers, because these are medications that might influence renin or aldosterone, and they will stop them for many weeks, 1 month, 6 weeks. This is a very long period of time. They will try to put potassium at exactly 4.0, right? Because you don't want low or high potassium to confound aldosterone levels. But this means that you have to stop medications that might help your potassium and then supplement very aggressively, and it can take time to do that. You will check the aldosterone and renin first thing in the morning, not at any other time of the day, because you want to control diurnal rhythm. And some might even adjust estrogen products or time it to the menstrual cycle because that is a potential confounder. So the benefits of this approach is that it is physiologically pure. And if you consistently apply it, you can interpret the results in a fixed and reproducible standard, just like a research study would. The downsides are patients are not in research studies, and this is a very intimidating and complicated approach. It takes a lot of time and effort, not only on the doctor's part, but on the patient's part. It requires communication, back and forth communication, home blood pressure monitoring, maybe prescription of medications, antihypertensives, and potassium to correct those, and multiple lab measurements. So this is a very complicated way to do this. And I'll just point out, it's so complicated that in the United States, in Europe, and I suspect in India as well, the number of patients who should be screened for primary aldosteronism is abysmally low. It's almost zero. For example, of those patients with resistant hypertension and hypokalemia, two very important reasons to screen, less than 3% of patients are ever screened. Okay, so already the screening for primary aldosteronism is very poor. And if you consider that the complex methodology to do so in a purist model is so difficult, it's not going to encourage this screening threshold to increase. So an alternative to the purist approach is the pragmatic approach. This is an approach that I would call, don't hesitate, recalibrate. With this approach, you measure renin and aldosterone in anybody you think could have primary aldosteronism at any time on any medication. And you focus on the components. What is the renin and what is the aldosterone rather than the ratio? What are you trying to prove? You're trying to convince yourself that the patient has renin-independent aldosterone production. So step one, is the renin suppressed? For renin activity, that's less than 0.6 nanograms per milliliter per hour, but also you can use more liberal, less than 1. If you use renin concentration, ideally less than 5 milliunits per liter, but even less than 10 is acceptable. Once the renin is suppressed, the second and most important and philosophical question is the aldosterone production inappropriate? So this is where there's a lot of interpretation. If you use a high threshold, like 15 nanograms per deciliter, you will detect more severe cases, but at the expense of missing many milder cases. If you use a lower, more liberal threshold, 10 or even 5 nanograms per deciliter, you will catch many more mild and moderate cases at the expense of false positives. So you have to ask yourself, what is your philosophy and what is best for you and your patient? To tolerate more false positives at the benefit of catching more cases, or to use a higher threshold and get lower false positives, but at the risk of missing more cases. This is something that each doctor and patient have to think about. A negative or uninterpretable screen, or something that requires a medication washout, is when the renin is not suppressed or the aldosterone is not that high. And I'll show you examples of this. So what are the benefits of this? It's easy, it's fast, It doesn't usually require medication washout or a lot of communication, and it decreases barriers to rapid and frequent screening. The screening is already abysmally low. This will help increase screening. The downside is you need to recalibrate your interpretations. You need to think a little bit about what you think is an inappropriate aldosterone production for each patient. So my general advice for testing is do not delay. If you suspect primary aldosteronism, go ahead and screen right there in the clinic at this moment. If the renin comes back suppressed, your results are very likely to be interpretable and useful. To maximize the sensitivity of the diagnosis, you lower your threshold for defining inappropriate aldosterone production in the context of renin suppression and hypertension. The lower the threshold will be, the more cases you will detect, but also the higher the false positive rate. Washing out or changing blood pressure medications takes a lot of time and effort. It puts a lot of pressure on you and your patients, and it is a laborious process that is not usually necessary. If the renin is unsuppressed or the pretest probability is high, then you can consider a medication washout until the renin is suppressed, mainly focused on mineralocorticoid receptor antagonists and ENaC inhibitors, but rarely is an ACE or ARB washout needed. And if the renin does not suppress after many weeks, this is a renin-dependent aldosterone production, a renal artery stenosis, renal vascular disease, reninoma, etc. So I'll summarize this with an algorithm that I use. This is published in JCM recently. Main essential indications to screen: severe or resistant hypertension, or any hypokalemia regardless of blood pressure. Other indications include hypertension with an adrenal mass or sleep apnea or a family history, but I think these indications will be expanded to include patients with milder forms of hypertension and hypertension and atrial fibrillation because the prevalence is higher there. To measure I think we have an unmuted mic.
Website to mute themselves. Mintu ji, if you can mute everybody else.
Okay, I will keep going here with this algorithm.
Mintu ji, please mute everybody else.
Okay, these are the challenges of Zoom. It happens all the time. So you measure a renin and aldosterone, and now comes the interpretation. If the renin is suppressed, now the probability of primary aldosteronism goes way up. If the aldosterone is greater than 15 nanograms per deciliter, I will refer to this as an overtly positive screen. The likelihood that this is primary aldosteronism is extremely high. If there's any evidence of hypokalemia, the diagnosis is confirmed. You can repeat on a different day in the small chance that this is a false positive, but that's very unlikely. This is what I would call the simplified confirmatory pathway. This is the easiest way to make the diagnosis because there's almost nothing else this can be. No fancy testing is needed. If the renin is suppressed and the aldosterone is very low, less than 5 nanograms per deciliter, this is very likely an exclusion of primary aldosteronism. And if you want, you can repeat renin and aldosterone on a separate day in the small chance that this is a false negative, but it's a pretty small chance. Another way to exclude the diagnosis is if renin is not suppressed. The caveat being, if the patient is on a mineralocorticoid receptor antagonist or ENaC inhibitor, medications that can raise renin, then you may do a washout and repeat testing. I consider this the simplified exclusionary pathway. This is the easiest way to exclude the diagnosis of primary aldosteronism. But what you will see in this algorithm is every pathway can end with the use or empiric use of spironolactone or a mineralocorticoid receptor antagonist. Because even if you exclude primary aldosteronism, if the renin is suppressed, you have still diagnosed low renin hypertension. And low renin hypertension responds very nicely to spironolactone as well as sodium reduction. So you can still prescribe these medications. There's almost no excuse to not prescribe spironolactone. So the tricky part is in the middle. If the renin is suppressed and the aldosterone is between 5 and 15 nanograms per deciliter, I still consider this a positive screen. A screening test should be highly sensitive. You should never miss true cases. So you call this a positive screen. And then you might need to do more work, what I will call the enhanced diagnostic pathway. If your patient is not willing to undergo more testing, you can empirically give them mineralocorticoid receptor antagonists. They likely have primary aldosteronism. They will likely respond very well. But if they are willing to undergo more testing, you can conduct a number of suppression tests, whether you prefer oral or IV saline or fludrocortisone or captopril, it doesn't matter. If they markedly suppress aldosterone, you excluded the diagnosis. But if there's a clear failure or even marginal failure of aldosterone suppression, you have diagnosed either mild or severe primary aldosteronism, which can then be localized and treated. So you have as many options as you want here, from empirically treating with an MR antagonist to going all the way to find surgically curable disease. But whatever your philosophical practice or your patient's needs, you should be able to diagnose and treat them here with one of many approaches. So I know there's maybe 10 minutes left. I can keep going with treatment, discussions about treatment, or we can stop and take questions. I defer to Dr. Amaya and others as to what you would prefer to do.
Anand, you can go on for next few minutes because
Okay.
We find it very interesting and informative also.
Okay. So I will talk for a few more minutes on treatment, and then if you want, we can do questions. Okay, so treatment of primary aldosteronism. So let me go back to the pathophysiology slide. This was a slide we reviewed earlier, and let's superimpose treatments here. So this is a pathophysiology of primary aldosteronism. The first treatment, I think this is the one that most people, maybe the most effective treatment, but the one that most people do not do, which is sodium restriction. As we reviewed, this disease is driven by distal sodium delivery. So if you remove dietary sodium, you cause volume contraction, decreased glomerular filtration, a decreased delivery of sodium to the distal nephron, which means no matter how much aldosterone there is, no matter how much mineralocorticoid receptor activation there is, you've decreased the amount of sodium that's being delivered, which means you will decrease volume expansion. And if volume contracts, renin and angiotensin II will rise. You can use a mineralocorticoid receptor antagonist. This will block the mineralocorticoid receptor in the principal cell to reduce ENaC-mediated sodium reabsorption, which will counter volume expansion. And if you titrate the dose high enough, you will again cause volume contraction and a rise in renin and angiotensin II. And finally, if you use surgical adrenalectomy to cure the disease, you will eliminate the excess aldosterone. You will decrease MR activation and ENaC induce sodium reabsorption, and again, renin and angiotensin II will rise. So the constant consistency between all treatments, whether medical treatment or surgical treatment, is that you will reduce MR activation, ENaC-mediated sodium reabsorption, you will reduce potassium and hydrogen ion excretion, volume will contract, and you will see an increase or normalization of renin and angiotensin II. This is just a table that shows that surgical approaches, whether it's curative unilateral adrenalectomy, even non-curative unilateral adrenalectomy in bilateral disease, lower aldosterone, raise renin, decrease the aldosterone to renin ratio. They improve potassium, decrease alkalosis, they decrease hyperfiltration, and GFR goes down, blood pressure drops, and the risk for cardiovascular disease drops. Medical treatments, whether it's MR antagonists or dietary sodium restriction, they don't address the aldosterone problem. Actually, aldosterone even rises, but they raise renin by volume contraction such that the aldosterone to renin ratio declines. They also improve potassium, base excess, and GFR, and blood pressure, and are associated with cardiovascular risk reduction. So one of the key markers is not just blood pressure and potassium, but a rise in renin. And I emphasize this because in observational studies like this one that we've conducted, you see that renin can be an important biomarker. Here are patients with primary aldosteronism who are treated with mineralocorticoid receptor antagonists or curative surgery compared to essential hypertensives who do not have primary aldosteronism. And what you see is their longitudinal risk for cardiovascular events, heart attack, stroke, heart failure. You could see that surgery to cure the disease lowers this risk, but mineralocorticoid receptor antagonist therapy is associated with a higher risk than comparative essential hypertensives, even though their blood pressures were similar. But it turns out if you stratify patients who are treated with mineralocorticoid receptor antagonists by what happened to renin, you see a different picture. You can see if you're treated with a mineralocorticoid receptor antagonist and your renin rises, it's not suppressed anymore, as a biomarker that you've adequately blocked the mineralocorticoid receptor, the risk is similar to essential hypertensives. You've mitigated the excess risk. The excess risk is related to those who are treated with spironolactone or eplerenone, and renin remains suppressed. In other words, you have not adequately titrated the mineralocorticoid receptor antagonist to block all the mineralocorticoid receptors. So the treatment algorithm that we recommend is, once you've confirmed primary aldosteronism, if you can prove unilateral disease, ideally by adrenal venous sampling, or in a very young patient with a clear-cut unilateral adenoma, the best treatment is surgical unilateral adrenalectomy. This is the best way to improve biochemical parameters, to improve blood pressure, and reduce cardiovascular risk. If your patient has bilateral disease or is unwilling or unable to undergo surgery, the treatment of choice is lifelong mineralocorticoid receptor antagonist therapy and dietary sodium restriction. The effectiveness of mineralocorticoid receptor antagonist therapy is boosted by dietary sodium restriction. So both of these together are ideal. And optimal medical therapy is normalization of blood pressure, normalization of serum potassium without the use of supplemental potassium, and some increase in renin to give you confidence that you've adequately blocked the mineralocorticoid receptor. So patients need to be followed on this treatment. What is suboptimal medical therapy? Suboptimal medical therapy means you've treated the patient with the mineralocorticoid receptor, you've increased the dose as high as you can, but blood pressure remains high. Potassium remains low, or they need supplemental potassium. Renin remains suppressed, or because the patient has chronic kidney disease, you keep running into hyperkalemia that prevents an up titration of the dose, or the patient has side effects, gynecomastia or other intolerance. In this situation, their cardiovascular risk remains high, so you can use other antihypertensive medications. You can use amiloride, an ENaC inhibitor, which is very effective on top of a mineralocorticoid receptor antagonist. If you run into hyperkalemia, this is very difficult. You can use potassium binders. The most effective is patiromer, which has been shown in clinical trials to improve this, but this is a very new and expensive medication. But on a case-by-case basis, you can also consider a non-curative unilateral adrenalectomy, not to cure the disease, but to attenuate the severity of disease. And this has been shown to also significantly improve blood pressure, potassium, and renin. And I would consider this if the patient has grossly asymmetric disease, one side looks bigger or is making more aldosterone, they have substantial cardiovascular or kidney disease, they take so many pills or medications that adding more is not beneficial, or they're very young. And if you do this, you're going to improve the clinical features, but you still will need mineralocorticoid receptor antagonist therapy. Hopefully the doses will be more tolerable and lower. Okay, I think that was my last slide. Hopefully that was a good overview for you of different approaches towards the diagnosis and treatment of primary aldosteronism in the contemporary times. I'm happy to take questions, and you can share your screen if you would like.